No, I don't think we are changing gear, being number 7 in the row, talking about the same topic, is a challenge. Uh, but let me give some perspective to the diagnostic aspects and the biomarker. I have some disclosures. So, of course, as we realize, 2/3 of the oncology meetings these days is about biomarkers, and we are talking about PD-L1, PD-1, which I would like to emphasize is just a little bit of a very complex immune system and very complex mechanism for escape, the tumor escape from the immune system. But that is what the companies are pursuing, and that is what we are dealing with these days. And PD-L1 immunohistochemistry is the assay all of them are pursuing. And we can see that across the borders, across organs, across drugs, it looks like PD-L1 positive tumors are doing better, at least if we're using response as a parameter. I agree with David that might not be the best parameter, but it is what we are doing in our daily life. Here are the 4 drugs most advanced in clinical development: nivolumab, pembrolizumab, atezolizumab, and durvalumab. And all of them are pursuing the PD-L1 assay. Now, the problem is, first of all, here, the assay are used are different antibodies associated to it. 2 of them are done by DACO, 2 of them are from Ventana. The next thing is, while after all the companies are pursuing tumor cell membrane expression, Genentech, Roche drug atezolizumab are also, as we touched upon earlier today, using infiltrating tumor cell expression. As we have heard about many times this morning, the cutoff levels for positive versus negative tumors are very different. Some are using 1%, some are using 5%, some are using 50%, some are using 25%. So that is also a confusing factor. So what is really a PD-L1 positive tumor? I'm confused about it. Of course, the prevalence of PD-L1 positivity will depend on assay used and will certainly depend on cutoff level used. Is it 20%? Is it 30%? Is it 40%? Of course, we don't know before we know the cutoff level used in the assays. So here are some examples from the different studies presented, and we can see here clearly the prevalence is varying. What is the magnitude of clinical relevance? We have discussed that many times. You have seen the curves repeatedly this morning. This is nivolumab versus docetaxel in squamous lung cancer, and the drug was approved without any biomarker. This is data in non-squamous lung cancer, and we can, as we have discussed earlier, also clearly see a difference between PD-L1 positivity For PD-L1 negative, there was overlap of the curves between nivolumab and docetaxel. This approval introduced a new term. We have been used now to companion diagnostics, and we know exactly what that means. We have the ALK story, we have the EGFR mutation story, we have the Pembro, which I will come back to. But what is complementary biomarker? That is a new term we need to learn. So the biomarker is not requested for being treated with nivolumab, but it clearly says in the label that there is an assay, blah, 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 definition, and if you're using this assay, the data shows clearly higher benefit, and if you are negative with this assay. So this is a new term, complementary biomarker. Is there a difference in response to immunotherapy between the two histology types, squamous, non-squamous? That can be discussed. It looks like it is. It would be natural if it was, because of two different histologies. So what we are dealing with here is pembrolizumab was FDA approved independent of histology, but with an companion diagnostics, and this one nivolumab with an complementary diagnostics. Then I think we heard about that this morning. Also, the variant of PD-L1 assay from Roche, Genentech, and Ventana, using both infiltrating tumor cells and expression on tumor cell membranes. And we can see here very clearly difference whether you are TC0 or IC0 versus any expression in one of the components. And we are starting also to learn from those studies what each component contribute to in terms of efficacy. Durvalumab data is also related to the PD-L1 assay. But all the first-line studies seems to be pursued in PD-L1 positive patients, and that is a little bit confusing because we have different proprietary assays applied. Well, some of them are currently being commercialized. We have different antibodies, cutoffs, and methodology as mentioned. So in my opinion, even if the companies have validated their assay, I'm sure they have, because that is a requirement from FDA, but it took several years for the scientific community to come into a scientific validation of the assays. And I can foresee very much confusion in the communities when you have 4 drugs approved with 4 different assays. So ISLC proposed for the companies what I call the harmonization project, to harmonize the PD-L1 assays. And of course, after some consideration, people called me up from the companies and said, Fred, you cannot call it harmonization project. We are not interested in harmonization on this stage. We want to pursue our own regulatory pathway and don't come up with an harmonized assay on this stage. So after a few months and discussion back and forth, we ended up with another title, characterization project, that is the so-called blueprint project. which now is also supported by AACR, FDA, and ASCO. But of course, all the companies are going together. We are sitting together around the same table and discuss how to move this forward. And the goal of the Blueprint project is to achieve a better understanding of similarities and dissimilarities between the different assays to produce educational tools for clinical use. And I, I can tell you I have a hidden agenda. I hope we can one day talk about harmonization of the PDL1 assay. We are already ongoing with this project. We have finished step 1. We have on the same set of tumors. In the first step, relative smaller number of tumors, 40 tumors, have been stained with all the different assays according to their SOP, and we have analyzed a lot of parameters. I hope we can have a publication on this within a couple of months before we go to step 2, which is a larger set of tumors where we will apply the same assays and validate our findings. And hopefully that will lead to some kind of recommendation in the future. We are, for post-marketing of the assay, we are not afraid to propose a harmonization. But pre-marketing, that is, of course, a very sensitive thing. ISLC is working with the companies to make an educational tool. We did that for ALK testing, which an atlas which has been extremely much requested all over the world. We have translated in Japanese, Chinese, Portuguese, and Spanish, and we have so many requests that we haven't really could meet all the requests. We are now revising also the atlas, but we will do a similar thing with PDL1 testing, and per today we have the companies buying into this project, and hopefully we can all collaborate to it. I think the mutation load as a predictive biomarker has been already discussed several times, also relating to smoking associated mutations. I don't want to go into this in detail. One thing I would like to talk about is tumor heterogeneity, and this I have shown this before. This is a tumor, 2 antibodies, complete negative on one part of the tumor for PDL1 and strongly positive for the other. And of course, if we take a biopsy in the negative area, this tumor will be characterized as PDL1 negative. Is this phenomena the reason why we see responses and good outcome also in some patients classified as PDL1 negative? That could be one reason. It could be technical reason. It could be real phenomena, but I think we should have that in mind when we interpret the results. One thing I'm missing in the whole scenario and for further drug development is what kind of other drivers are in the space of PDL1 positive and PDL1 negative field. Of course, that you wouldn't start out with an PDL1 antibody for a patient who is EGFR mutation positive or ALK positive. So there needs to be more substantial data on what are those two spaces containing. 10 years ago, we talked about EGFR mutation positive and EGFR wild type. Today, we know that the wild type space is split up in 20 different subgroups. We need also to figure that out for immunotherapy. I don't want to go into the prognosis. There are conflicting data. What is a prognostic association of PD-L1 expression? We need to figure that out. As I said initially, we are dealing with a little piece in a very complex system, and I think we will learn much, much more of that in the future. I like this one very much, of course, with my interest in biomarkers. Center for Everything but Validation and Standardization is the key points. And if you come to our meeting in January, which we have together with AACR, you will learn much more about these things. So welcome. Thanks.
So thank you, Fred. And I think